Delighted now to introduce our second and perhaps overall the most argumentative person any of us know. Busy, challenging, powerful people right across the world, especially in Europe. Peter Gøtzsche has been a champion, as we know, of rational prescribing, rational decision-making, and he's going to tell us about some controversies that he's currently dealing with. Thank you very much.
Thank you. Yesterday afternoon, I heard church bells ringing for 3 hours. So I got pretty annoyed. I had difficulty concentrating. It was just 200 meters away from my hotel room. So I went to the church and asked them, has Jesus come back? And then they replied, no, he comes next week. So, you know, I love British humor, and the religion, I mean, I'm now going to talk about mammography screening, and the National Health Service rings the bells for mammography screening every day, and the women faithfully attend to it as if it were a religion, although it is harmful to them. And this is what I will demonstrate now. 2 years ago, I published an editorial in God's neighboring country, Canada, time to stop mammography screening. It had a question mark at that time, but I have now removed the question mark. We should stop mammography screening, and I'll explain why. First of all, consider the randomized trials. It's very strange that those trials that have reported the largest reduction in breast cancer mortality have used poor equipment, had long intervals between screens, screened the control group early after only 3 to 5 years, so there was very little treatment contrast, and then used only one view mammography. This doesn't make any sense, and it tells you something about bias, that some trials are better than others. Now, we divided the trials into 2 groups, and the best trials found a reduction in breast cancer mortality of 10%. And the poor trials reported a reduction in 25%. Now, which is correct? I have published a paper with 2 colleagues where we looked at tumor size, because tumor size is related to the risk of metastasis. So we could calculate that the old trials could not have found an effect greater than 12%. So actually, the best trials are those that come closest to the truth. Screening has never reduced breast cancer mortality by 20 or 30%. No way. It's not possible if you look at the tumors. Okay, we'll go on. Now, I also looked at the relation between how effective screening was and the effect on breast cancer mortality. If screening is very effective, you find few women with positive nodes in the screening group. That's obvious. That's why you screen. Okay? So, few women with positive nodes in the screening groups, it's down here. And a large reduction in breast cancer mortality is down here. So a small trial in Gøtzsche found a huge effect both on those positive tumors and mortality. And if you do a regression analysis, you find a clearly significant relation between node positivity and breast cancer mortality. Everything is fine, apart from one thing. The regression line is in the wrong place. For a screening effectiveness of 0, you still find a reduction in breast cancer mortality of 16%. This is just impossible. The regression line should have been up here, so for 0 effect, you find 0 effect on breast cancer mortality, but it's in the wrong place. And I could also see that both determination of node positivity and determination of cause of death, they were both biased in favor of screening. So there is a huge amount of bias in these trials. You should be aware of this. Okay, we'll go on. And misclassification of cause of death is very common, and it favors screening. And one of the misclassifications that is common is that you assign the death to another cancer, because some of the women have more than one cancer. So I also looked at total cancer mortality, including breast cancer, and what did I find? Nothing. If screening had reduced breast cancer mortality, you would have expected to find a reduction in total cancer mortality, and you didn't see anything. That's another worrying finding. And here comes one of the most worrying findings that was published only some weeks ago in the BMJ by Mike Baum. Screening doesn't save lives, because one of the reasons is that radiotherapy kills healthy, overdiagnosed women. Mike Baum was the first one who quantified this. I have written about it for many years in our Cochrane review, but Mike quantified it, and he used data from randomized trials. Of course, radiotherapy increases the risk for lung cancer death and for myocardial infarction death. And when we allow for better treatments, since the old trials were done, Mike found that 3 to 4 per 10,000 screened women avoid dying from breast cancer, assuming a large effect of screening, 15 to 20% on breast cancer mortality. But at the same time, 3 to 9 per 10,000 will die from lung cancer or myocardial infarction. And there will be even more deaths, because these are only 2 causes of death. Radiotherapy kills by other means as well. So, the screening doesn't save lives. That's pretty clear. Now, we have another demonstration that screening doesn't save lives, because it even doesn't reduce breast cancer mortality, at least not in Denmark, which is the only country in the world that has a control group because of me. So we have a control group of 17 years, and what you can see, the age group that could benefit from screening, you can see breast cancer mortality went down after screening was introduced. That is the red one, but it went down equally well in the rest of the country that didn't screen. Introduction of effective treatments. It's not an effect of screening. And you can see that on the next slide. Annual reduction in breast cancer mortality was 1% in the screened areas and 2% in the non-screened areas. And in the young women who could not benefit from screening, it was even larger. It's better treatments, it's not screening. Okay. The coup de grâce. And I call it coup de grâce because it was a Frenchman, Philippe Gøtzsche, who delivered the coup de grâce in BMJ. He compared neighboring countries that had introduced screening 10 to 15 years apart. So you can see in Sweden that introduced screening very early and came up to a high percentage of the population very early. And you can compare with Norway that introduced screening very late. You have Northern Ireland and Republic of Ireland. You have Netherlands, you have Belgium and Flanders. And what do you see? Archie Blyer, an American, made this very nice figure that breast cancer mortality has decreased everywhere, also in the United States, and it started at about the same time, which is when we introduced effective treatments. If this picture isn't convincing, I don't know how I shall ever convince anybody about stopping mammography screening. This speaks volumes, this graph. Okay. Here is another coup de grâce, also delivered by Philippe Gøtzsche, because he looked at whether screening reduced the occurrence of advanced cancers. That's the whole reason for screening. And he had data from various countries, and the rate of advanced cancers, defined as those bigger than 2 centimeters, was not reduced with screening. In Norway, they introduced screening in a staggered fashion, so they had a control group actually. And also there they found the rate of advanced cancers, which were here stage 3 and 4, was exactly the same in screened and non-screened areas. So again, the evidence we have is, I would say, very convincing. Now I turn to overdiagnosis, which is the major harm of mammography screening, as it is with prostate cancer screening. That's the detection of cancers which would not have been detected clinically in the remaining lifetime of the people, so it wouldn't have been a problem. Many of these cancers are slow growing, of course, or they don't grow at all, or they regress, which Per-Henrik Saal, who is here today, has shown in 2 beautiful studies. But some of them grow very quickly, and then if the woman gets a myocardial infarction and die before they would have become clinically apparent, it is still an overdiagnosed cancer. Okay, we did a systematic review of countries with organized screening programs, and our results were remarkably consistent, and what we found was an overdiagnosis of about 50% in these countries. It's very high. And here you can see data from Britain that are also frightening, or from the UK. When screening started in the UK in '88, you can see that in the screened age group 50 to 64, the incidence of breast cancer went up very much, and it stayed high. You can see that, very high. But the most shocking finding is that when screening was extended to ages 65 to 69, there was a new skyrocketing of the incidence of breast cancer, which doesn't make sense because all these women have already been screened. Why so many new cancers? This can only be explained if screen-detected cancers melt away without treatment, as Per-Henrik Saal has shown. This is very convincing evidence that the cancers we detect at screening is completely different from clinically detected cancers. And yet in Britain they are proud that they extend the age ranges all the time. I mean, I don't get it. It's religion. Here is another important study done by a Danish colleague and a Dutch statistician, I think he is. He studied the consequences of false positives. And here is one example on anxiety. What you can see is that even 3 years after the false positive was deemed normal, so the woman doesn't have breast cancer, the anxiety level lies between those who did get a diagnosis of breast cancer and those who have been perfectly healthy all the time and didn't get a false positive diagnosis. This is also very worrying, and if you do a utility analysis, considering that it doesn't save lives, and it creates a lot of overdiagnosis and unhappiness through doing that, and worries about false positives, you can imagine any utility analysis must come out negative. This is why I tell you mammography screening is immensely harmful. And now the 2 fat lies about breast screening. Screening saves lives and screening saves breast. You know it doesn't save lives, it doesn't save breast either. When screening was introduced in Denmark, it produced 2 mountains of removed breasts. And it was never compensated for later by a valley here. It was about the same. So you remove a lot of breasts in people who it would have been nicer to have them in situ on the chest, wouldn't it? It's actually quite terrible. So stop screening. By stopping screening, it should be stopped on a national level, but a woman can stop going to screening, and by so doing, she will lower her risk of getting a breast cancer diagnosis by 1/3. It's the most effective way we have to reduce the incidence of breast cancer. Stay away from screening. We don't know anything that is more effective than that. Screening doesn't work, and it causes breast cancer. You may say, can I say it causes breast cancer? Yes, it does, because it gives you a breast cancer diagnosis with all the unhappy consequences of that. I had enough a couple of years ago, so I published this book, Truth, Lies, and Controversy, about screening, which has been well received everywhere apart from the Lancet. So I had to publish a letter where I pointed out all the errors in the book review, or some of them. There were many. I also wrote a leaflet to inform the women, which was published in the BMJ some years ago, and volunteers have translated it into many languages, as you can see, including Arabic and Russian and 2 versions of Chinese. It will also come in Urdu and Korean and Brazilian Portuguese and undoubtedly other languages. Why do people do this? Because also in their country, information about screening is one-sided and dishonest. So people do this to help women all over the world. And they are on our website, all these leaflets. So the last thing I will tell you is there is only one interesting question left about mammography screening, and that is which country will have the political guts to be the first to stop mammography screening. I hope it will be my country, Denmark. Thank you.